Hi, my name is Raffaele Califano. I'm a consultant medical oncologist at the Christie Hospital in Manchester and an honorary professor at the University of Manchester in the United Kingdom. I'm here at ASCO 2025 as we have presented the data of an analysis from the MARIPOSA-2 study evaluating the impact of the baseline mechanism of resistance on progression-free survival. Just to refresh your mind, the MARIPOSA-2 study was a large phase 3 randomized clinical trial which evaluated patients with advanced EGFR-mutated non-small cell lung cancer whose disease had progressed from osimertinib as a later line, and patients were allocated to receive standard chemotherapy with carboplatin and pemetrexed or chemotherapy with carboplatin and pemetrexed plus amivantamab, which is a dual EGFR and MET inhibitor, or carboplatin pemetrexed plus amivantamab plus lazertinib, which is a third-generation EGFR tyrosine kinase inhibitor. The study has already been reported. It's a positive study which demonstrated that the addition of amivantamab or amivantamab lazertinib to chemotherapy improves progression-free survival when compared to standard chemotherapy alone. And the regimen with carboplatin and pemetrexed plus amivantamab is now been approved as an option by EMA and FDA in this setting. What we analyzed in this data set was the mechanism of resistance from osimertinib on plasma samples. So all patients who went into the study donated a baseline plasma sample. We analyzed the ctDNA, and we performed next-generation sequencing to look at baseline molecular aberration as a mechanism of resistance. Approximately 87% of the patients had a blood sample which was evaluable for ctDNA, and we performed next-generation sequencing using Guardant 360, but also predicting care assay, and we were able to determine the baseline mechanism of resistance. What we found was that in patients with detectable ctDNA, the most common mechanism of resistance were MET amplification, approximately 15% of patients, or secondary EGFR resistance mutations such as C797X, and they were approximately 15 to 18% of the patients. When we analyzed the impact of these molecular aberration in terms of PFS, we saw that with a median follow-up of 8.7 months in patients with detectable ctDNA, the combination of chemo plus amivantamab achieved a longer progression-free survival when compared to chemotherapy alone. We also looked at the presence of p53 mutations at baseline, and again, the addition of chemo plus amivantamab achieved a longer progression-free survival when compared to standard chemotherapy alone. Looking specifically at the mechanism of resistance, what we saw that the combo arm, so the investigational arm with chemo amivantamab, achieved a longer progression-free survival in patients who had MET-dependent and EGFR-dependent mechanism of resistance, but also in patients with MET and EGFR-independent or unknown mechanism of resistance. With more granularity of the data, we looked specifically at MET amplification, and again, chemo-ami achieved a longer progression-free survival when compared to chemotherapy alone, with an hazard ratio for a PFS of 0.55. We also looked specifically at secondary EGFR resistance mutation, and the hazard ratio again favored chemo-ami for progression-free survival with an hazard ratio of 0.51. So in summary, what we demonstrated is that the combination of chemotherapy plus amivantamab improves progression-free survival over standard chemotherapy regardless of the baseline mechanism of resistance post-osimertinib, and this confirms that the MARIPOSA-2 regimen remains a standard of care in this setting. We know that it's very important for patients whose disease was exposed to osimertinib to try and understand how the biology of the tumor has changed, therefore trying to identify mechanism of resistance to osimertinib. Ideally, patients should have a rebiopsy, but this is not always feasible or safe for the patient, so we're now using plasma next-generation sequencing to try and understand what's the mechanism of resistance. Now, plasma has got pros and cons. The pros are that it's a non-invasive method, so you can draw bloods, but the potential benefit of drawing bloods and analyzing that for next-generation sequencing will depend on the quantity of the ctDNA that you can actually find in that given sample. On the other hand, if you rebiopsy the tumor, you're in the tumor, you usually achieve a good yield from the biopsy, and that will allow you to run your molecular testing and find the molecular results. What is very fascinating is that for patients with identifiable ctDNA, we should be able to have a more comprehensive landscape of the genomic profile, as we can capture in plasma shedded tumor cells from different sites, whilst, of course, if you biopsy only one site, you're going to have a profile which will reflect the genomic alteration of that given site of progression. So there is a lot of research looking at using ctDNA to guide next steps and try and improve patient outcomes, tailoring the treatment to the single genomic profile of that disease progression. What I think is fascinating in thoracic oncology is that we are gathering a better understanding of the molecular biology of the tumors, and we're therefore able to try and tailor with specific agents the treatment for a given molecular aberration in a given patient. So we are trying to move away from an approach which is a general approach. I think it's important to think about the fact that plasma NGS is not always feasible, and also rebiopsy is not always feasible. So it's good to have an all-comer option as the MARIPOSA-2 regimen with chemo amivantamab, but it's also important to look at specific molecular subsets to find some targeted therapies which may influence the course of the disease for that specific genomic alteration.